Dear friends, colleagues, what a happy day for me to have all you together in this day. I want to start this Zoom. This Zoom is like a scientific, social, and emotional meeting. For me, it's very emotional to have a lot of my friends here and see them all. Many of them, it's a long time I don't see them, and it's very, very provocative to have all them together. I want to make a little comment on where we are with the World Society of Arrhythmias at this moment, and I want you to know that we have constituted an executive board that is working very hard to propel the society forward. We were in to register in New Jersey, but we had to cancel that, and now we are almost finishing to register in Geneva, and will affiliate with the World Heart Federation very soon. As you know, we need new and younger members, and because we are a group of white male dominating this group, and we don't want that, we are sending invitations very soon to new members, and that's going to be important for the continuation of our society. We have conducted a SWOT analysis, and we are using this to refresh and redevelop the society. One of our first moves is to offer today's scientific program through this 2-hour Zoom, and we felt very rewarded by the response of today's speakers to our invitation. We have also submitted 2 sessions for HRS in Boston 2021, jointly with the Indian HRS and the Japan HRS societies, and arrangements for Istanbul for 2023 in Turkey are being developed. We are now planning to be not competitive with the HRS, ERA, AP, HRS, and LARS. We are certain that we will be able to fill a niche which will be complementary to the great work of the large regional societies. We need to have our group as an education, science, friendship, and cooperation group that are the goals of our week, of our society. We feel confident in going into 2021 that we have a viable society for that, and with a new base, young and greater action between now and the World Congress of 1923. So I want to welcome all you, dear friends, and the basic of this is to say hello, and let us start with what we can do for today and be away. We're moving. And now I want to introduce Dr. Ricardo Esperanza, president of our local SADC society, who was very helpful for me to do this. And he's going to say a few words because we are now 1 year late after the World Congress last year in Argentina. Ricardo, go ahead, please.
Thank you very much, Oscar. Good morning, everyone. It is a pleasure for SADC to share this activity with the World Society of Arrhythmias. 1 year ago, we had the 16th World Congress of Arrhythmias, an event with more than 2,000 attendees with a high-level scientific program. We had the most important opinion leader as a speaker. During 2020, despite the difficult context due to COVID-19 pandemic, SADC was able to perform many academic activity with prominent speakers, gathering a large number of colleagues from Argentina and the rest of the world. Today, we are very happy joining the World Society of Arrhythmias with the participation of outstanding international speakers. I hope you enjoy. Next, I am proud to introduce you Dr. Thomas Deering. Dr. Deering, welcome.
Thank you very much, Oscar. It's an honor to be here. I thank you for putting together this program. I'd like to do two things. First of all, just give a brief commentary on your topic about COVID and where we stand. 2020 is clearly the year of the pandemic being a Greek word, pan for all, and demos for the people. So it's a global issue, and it's affected all of us individually and collectively. But I'd like us not to just look at 2020 as the year to forget, but as a year to remember as we move into 2021. And remember, basically at two levels: to remember our friends, our colleagues, our relatives, our patients who have passed away, some from COVID, some from other events, and remember how they enriched our lives and made us better human beings, and try to translate that to our other friends, colleagues in the next generation. And also thanking our colleagues who have passed on for the great work they did in advancing science and care delivery, so that as a society, globally, we can do better across the world. What I'd like us to remember are a couple of things. First of all, I think in the pandemic, we learned how to function more as a team. Whether that is cross teams working with our critical care docs, our ER docs, our primary care docs, or whether it's within teams covering for individuals who got sick or had compromising diseases, so couldn't cover the hospital. I think we came together more as a team. And I think that's something that we need to look forward to as we go forward, so that we build, grow, and develop those things. I also think research is something that we need to look at. Clearly, it's the foundation upon which our field is built, and it will remain such if we continue to innovate and to develop. Look at how quickly the vaccines came along and the distribution channels that are being put together to make them globally available. So maybe we can think deeper about how we can expedite new technologies and new approaches, and look at how they have impact on healthcare outcomes. So I think we should think about that as we go forward. And lastly, but not least, is education. Look at this meeting today. A meeting like this would not have been thought of 3 years ago. So I think it's one of those things where education for patients and education for clinicians has taken a new step forward. And we need to think about how we can make face-to-face meetings more meaningful, more vibrant, more beneficial, while also figuring out how these type of virtual meetings work as well. So I think that's what I'd like to just leave as thoughts moving from 2020 into 2021. I'd like to make one other additional comment and then introduce our next speaker. So the comments are related to that speaker. That's Dr. Mark Estes, who is a colleague, friend, and mentor to me. I have immense respect, as do all of you, for Mark and for what he has accomplished. And I want to give him a shout out for being awarded the 2020 Heart Rhythm Society Distinguished Teacher Award. And that to me is a great award. It's certainly important to win other awards, but teaching people not only, makes them better in their career, but it has impact for patients everywhere. After his training, Mark spent most of his career at Tufts New England Medical Center, is now at the University of Pittsburgh. He has, as you all know, a prolonged CV with over 800 publications at a variety of levels, from peer-reviewed articles to editorials to authorship for chapters. He's been a journal reviewer for multiple journals and sits on editorial boards. But that isn't really what this award is about. This award is about his teaching. Over the years, whether it be medical students, or whether it be interns and residents, or whether it be fellows, he's committed to education. He has trained over 54 fellows in his career since starting it at Tufts and now at Pittsburgh, 54 EP fellows. And in addition to that, he's coordinated the Heart Rhythm Society, board review course for clinical cardiac electrophysiology. He did that for over 13 years, and then started a program, EP 101, for incoming EP fellows to get them off the ground and get them running. And that certainly has been influential in many people's careers, going forward. So he's done a great job in that. He has also won awards for his work elsewhere, locally from the American Heart Association, from the European Cardiac Arrhythmia Society, and from HRS. And this is just one of many that are well-deserved. But when I think about it, I use the word care, because that's really what teaching is about. And I use that moniker with the C. Mark has compassion for everybody, and he has commitment to doing the right thing and helping everybody get forward. As A, he's an advocate for those who work hard and work with them, and he gives advice that is always sage. For R, he shows respect from the janitor to the CEO and treats everybody equally. But he respects responsibility, expects people to step up. And he provides excellence in what he does and enthusiasm, which is a model. So it's that example and that emulation that counts. So that's my 5 minutes. I'm going to stop there and introduce Mark as our next speaker. Mark kicks this off talking about science in a pandemic. Mark.
Well, thank you, Tom, very much for those kind, if somewhat hyperbolic comments. It is true that education has been a passion, much like clinical care and also science. As I look back over my career, as I've told Tom, one of the most important things I think we all have as our legacy is the scientific and academic accomplishments of our fellows. And in that respect, Tom, just keep up the good work. So with the move to Pittsburgh, I inherited some new responsibilities with the American Heart Association. And in that respect, and Oscar, I'm just to set a precedent, setting a time clock here so that we won't go over 5 minutes. I became the chair of the scientific publishing committee of the American Heart Association, overseeing 12 journals, including 5 core journals. And it became clear to us in February and March that we had to initiate a response, an immediate response for all of our journals. We issued statements on behalf of all the journal editors. It's over 60,000 authors and reviewers. But we also, in meetings with the editors, reinforced scientific rigor for all publications, ensuring that every single publication had 2 highly qualified reviewers and a statistics reviewer. We were indeed mindful of the vulnerabilities of trying to get science through an accelerated process. We expedited all our publications for COVID-19. We established a website. All papers became freely available. And we also had a compendium page for professionals, which we put daily into our professional Heart Daily. It goes out to over 250,000 physicians, and then did weekly emails as well. We did a series of videos with local experts that were extremely popular, really focusing on the clinical management on a global scale. We wanted to take an international perspective on this, and these were extremely well received from clinicians in the front lines looking for the best possible advice as to how to manage patients.
Lo presento yo, negro, no hagamos complicación. Yo estuve viendo eso. Yo lo presento.
We also looked at our website usage very, very carefully, and we saw some very interesting trends. We approached several million hits on our website. And in contrast to prior years in which 2/3 of our activity was from the United States, what we found was that the rest of the world was indeed accessing our website on circulation and downloading journals at rates that were 3 times what we normally saw. In particular, obviously, our publications, our scientific publications related to COVID. We had over 3,000 of them. We accepted about 10% of them. And each one of them, we gave them very careful consideration. We did that in part because we recognized the vulnerability, and that vulnerability came to the forefront, unfortunately, in early June of this year, when both the New England Journal of Medicine, which looked at cardiovascular disease, drug therapy, and mortality in COVID-19, in which the premise that ACE and ARBs in patients with cardiovascular disease resulted in worse outcomes was undermined by this publication, and also one in the Lancet. So this is the number 1 and 2 medical publication in the world based on impact factor, based on circulations. And in the Lancet publication, there were indeed indications that hydroxychloroquine, with or without a macrolide, might increase ventricular arrhythmias. How do these premier journals get it wrong? Well, the peer review process failed. There were flags all over the place. how could a small company in Chicago get data on 1,200 patients with 1,200 hospitals up to 100,000 patients? Well, it was just impossible. We faced some real dilemmas as a publication committee. One of them was this. We received a small early report from France about this multi-system inflammatory system in children. And the numbers were small, 30 patients. But we had this looked at very critically by our epidemiologists, and you can see that red spike increasing the frequency of a Kawasaki disease-like syndrome. It was not only a temporal, but a geographic relationship. And indeed, we published this showing that corticosteroids, in addition to immune globulins, improve outcomes. We got it right. It's been used not only because it's been used by the World Health Organization, which suspended treatment based on the Lancet in New England of hydroxychloroquine. So there is a trend towards open science. It's being pushed, as many of you know, by Plan S, but it needs to be balanced by scientific rigor. We got it right because of robust peer review, preprint servers, and Office of Scientific Publishing. And we're now reevaluating our mission, looking at a focus on worldwide societal benefit. So down to the second, Oscar, that's my presentation. And I appreciate the opportunity to present to my colleagues. Thank you.
Thanks a lot, Marky. We feel very proud having you in our group. Thanks for your short presentation, but so important. For next speaker, I am going, Claudio de Zuluaga is not able to connect. So I'm going to introduce Greg Lipp, who is going to take his title. He's from Great Britain. And Greg, thanks. Just as the first one I'm presenting after Marky, we are going to say only the name and the country just to be short in time, but all of you, we all know you are very important opinion leaders of the world. Dear Greg, go ahead, please.
Thank you, Oscar, for a very kind introduction. And I've been asked to cover atrial fibrillation management in 5 minutes. So I suppose I have to take the starting point that it's going to be as easy as ABC. And in trying to present on this, maybe we should take a look back at any textbook or any book chapter, any guideline from the last decade. When we try and manage atrial fibrillation, it will cover the following topics. It will mention about stroke prevention. It will talk about symptom management and discuss rate control and rhythm control, and recognizing that atrial fibrillation patients have multiple risk factors and comorbidities. Any textbook or guideline would draw attention to risk factors, comorbidities, and now increasingly lifestyle type changes for the management of atrial fibrillation. We therefore need these simple and practical decision-making processes because atrial fibrillation patients are managed not by the specialist electrophysiologists, but by general practitioners, by non-cardiologists, by the emergency room doctor, and of course by the cardiologist. But even before the patient enters this patient pathway or patient journey, we have to improve the awareness, the detection, the characterization and evaluation of the patients with atrial fibrillation. And this, I'm not really saying anything new to our audience. This is any textbook, as I mentioned, any guideline. And of course, this is reflected in the new 2020 ESC, European Society of Cardiology guidelines for the management of atrial fibrillation. And the management of atrial fibrillation can be summed up as CC to ABC. And what does the CC stand for? Firstly, confirm the diagnosis, make sure that you evaluate and investigate appropriately and confirm the arrhythmia. Secondly, characterize. The second C is characterize the atrial fibrillation. This is the 4S scheme, referring to stroke risk assessment. We have the CHA2DS2-VASc score, symptom severity with the ERA symptom score, severity of AF burden, dealing with paroxysmal, non-paroxysmal atrial fibrillation, and the final S refers to substrate severity with age and comorbidities and structural heart disease identified by cardiac imaging. And therefore, you have the CC, and from the CC, you go into the management and treatment, which is the ABC pathway. And what does the ABC pathway stand for? Simple as ABC, because A is avoid stroke, or A is avoid stroke with anticoagulation, and the default is stroke prevention unless they're low risk. The B is better symptom control with patient-centered and symptom-directed approaches to rate control or rhythm control. And finally, C, cardiovascular and comorbidity risk optimization, including attention to lifestyle type changes, attention to psychological morbidity associated with atrial fibrillation. And in terms of the stroke prevention side, the algorithm is kept simple because the default is stroke prevention unless they're low risk. So in the cases of atrial fibrillation without significant valvular heart disease, rather than prior guidelines being obsessive about identifying high-risk patients, the first step is identify the low-risk patients. CHA2DS2-VASc score 0 in males and 1 in females. No antithrombotic therapy is necessary. Then the next step is to offer stroke prevention to patients with 1 or more stroke risk factors. You're offering anticoagulation, which is stroke prevention, attention to bleeding risk assessment, and we have the Hasbird score recommended. And finally, step 3 is the choice of anticoagulation, and the ESC guidelines, like most of the guidelines internationally, are preference towards the NOACs. Now, I mentioned the Hasbird score in terms of bleeding risk assessment because bleeding risk assessment and bleeding risk evaluation tends to be misused by the ill-informed. This is a prospective cluster randomized trial where the using mobile health technology based on the ABC pathway and the Hasbird score evaluation in a cluster randomized trial. That's the intervention arm, and on the right is the usual care arm. As you can see from this data from the MARTHA-2 trial, appropriate and responsible use of bleeding risk assessment with the Hasbird score is associated with less bleeding and actually an increase in anticoagulation use at 12 months compared to the usual care patients. So to sum this up in my last minute, regard to the CC to the ABC, I mentioned before how AF patients present to GPs, to non-cardiologists, to cardiologists, but central to all this is the patient with atrial fibrillation. So the patient journey is to all these different healthcare professionals, starting with the awareness and the improved detection of patients with atrial fibrillation, entering into this holistic and integrated approach to the management of atrial fibrillation. So patients central to all this get a consistent message, whether they are managed by the GP, the non-cardiologist, and the cardiologist. And that's the ABC pathway. I've talked about this earlier. A, avoid stroke, B, better symptom management, and C, cardiovascular and comorbidity optimization. And if you superimpose the previous figure, this is what we have. Easy as ABC, a simple strategy streamlining primary and secondary care management of patients with atrial fibrillation, starting from the awareness and then improved detection of AF into a structured and follow-up of patients based on the ABC pathway. Thank you for your attention.
Excellent, Greg. Thanks a lot for joining us. Next speaker is my dear friend, John Kam. Please, John, go ahead.
Good morning, everybody. Thank you, Oscar, for the invitation. I intend to talk for a few minutes about the EAST AFNet-4 trial. It was presented at the ESC and published in the New England Journal. The title of the paper was Early Rhythm Control Therapy. Before I continue, I just have to show you that I have some potential conflicts of interest. All of these companies supply some product or other related to atrial fibrillation. Bear that in mind. Let me start by reminding you that we have a number of trials designed to investigate the strategies of rate and rhythm control, make a comparison between them. Most of these were conducted 10, 20 years ago, but you can see that they all produced a consistent result. There was essentially no statistically significant difference between rate and rhythm control. One exception was the J-rhythm study in younger patients, mostly with paroxysmal atrial fibrillation, a very complicated composite endpoint, but it was a statistically significant result in favor of rhythm control. The EAST trial started about 10 years ago, and essentially it was to investigate the strategy of early rhythm control versus usual care. Usual care, as defined in the guidelines, essentially rate control unless patients are highly symptomatic, in which case one could change to rhythm control. Early rhythm control meant that the patients who were recruited to this study had atrial fibrillation for less than 1 year. You can see that about 1,400 patients per group were enrolled into the study. The demographics of the patients in the early rhythm control and the usual care arms was virtually identical. And you can see that the average time that they'd been in atrial fibrillation was 36 days. And in many instances, about 40% of cases, it was the first episode of atrial fibrillation that they had suffered, as far as was known. There was some slight difference in the drugs used in management. You can see there was more rate control medication in the usual care group, perhaps not surprisingly, but patients in the early rhythm control group were taking antiarrhythmics, often with associated rate control. You can see that both groups were very adequately anticoagulated. This summarizes the treatments for rhythm in the early rhythm control at discharge and at 2 years of follow-up. You can see ablation only constituted a small proportion of the rhythm treatments in these patients. Most were the conventional antiarrhythmic drugs. You can see in the usual care group, there was virtually no rhythm control initially, but over a 2-year period, you can see that this increased to about 13 or 14% of the patients receiving rhythm control therapy. The results are on this slide. To the left, you can see the Kaplan-Meier curves, and you can see that the patients treated by early rhythm control did better than those who underwent usual care. This was statistically highly significant. If we look at the primary outcome, which was a composite of these 4 features, you can see that there was a 21% reduction. Amongst the components of the primary outcome, we can see that CV deaths was reduced by 28% and stroke by 35%. If we look at the second primary outcome, it was the nights spent in hospital. And contrary to other rate versus rhythm trials, we can see that there was very little difference in the hospitalization rate between early rhythm and care. It's important to notice that sinus rhythm was pretty common at patients who received essentially a rate control therapy. Less, however, than those who were having rhythm control. So finally, on this last slide, I've added EAST to the strategy trials which look at rate versus rhythm. EAST not quite the same and obviously involves some more modern therapies, but essentially it reduced the issue of acute coronary syndrome, worsening heart failure, hospitalization, CV death, and stroke from 5 to 3 per 100-person year. Thank you very much.
Thank you, John, for this excellent summary. And now it's my pleasure to introduce.
Thank you very much. I am very glad to seeing you after all this month of pandemic. And I was asked just to give few remarks, and I think these few remarks are somewhat linked to John's talk, in terms that apparently rhythm control is getting more and more important after this trial. And one way to treat AFib is ablation. And you know that several advanced and new features have appeared in recent years about improving ablation. And one of them is using different ways of delivering RF in order to make the procedure more efficient. We know that the RF current produces a heating of the tissue that is based on 2 components. The first one is resistive, so the RF current creates resistive heating, and this heat is conducted to the rest of the tissue and creates a secondary lesion that is related to conductive heating. Of course, there are some restrictions to this heating, and you can increase the amount of RF that you can deliver to the tissue by increasing your contact on the catheter and by irrigation. So one way to go, once you can increase your power, is to let's say the same amount of final RF given, you can give a small power for a long duration, or you can give a high power for a short duration. This will create, for the same volume of lesion, different components. In the first one, it will be mostly related to conductive heating, and for the second one, mostly related to resistive. Are these two lesions, apart from the size, similar or different? What we know now is that they are different. The conventional one is in general deeper, and the new way of creating lesion, high power short duration, produces wider lesions and less deep lesions. There is intense lesion size, but there are other consequences. One is that the application time logically is reduced dramatically, and this influences the duration of the procedure and also influence that the lesions created are more stable because you need to take your catheter shorter in a given position, and this has also influences in the outcome. The first published paper was last year, and in this paper, a multi-center trial, they used a special catheter, and they used 90 watts. The results were in the line that I was explaining, so it was mostly a preliminary, a small short study, and they showed a significant reduction on the procedural time. Complications were not really important, although they were not studied in detail because the number of patients were very small, and the esophageal damage was not really tested. After that one, there is another paper from a German group using now regular catheters with 70 watts, and they found apparently, compared to the conventional way, a superior efficacy. We also published this paper and compare here not only the efficacy, but also the safety. And we use in all of our patients endoscopy the following day. And here you see the results. In the conventional groups, we were able to find some lesions, but this was not the case when we were using high power for short duration. So some take-home messages. In summary, PVI is feasible with high power short duration RF application. Total RF time can be reduced by this approach. And apparently there is a low incidence of esophageal damage, especially with much higher power. Thank you for attention.
Thank you very much for that very informative presentation. To keep us on time and moving to our next speaker, I'd like to introduce Dr. Michael Glickson from Israel, who'll be talking about left atrial appendage occlusion and where we stand today. Michael? Michael, you're on mute. You're on mute.
Thank you very much. Thank you for the invitation to present this topic of the update on LAA occlusion. I hope that you can see my screen. Actually, this topic goes back to this paper that was published 2 years ago. I had the opportunity to share this consensus paper together with Bernard Meyer from the EAPCI, which represented the current knowledge at that time. As you know, the knowledge base behind the LAA occlusion are 2 randomized controlled trials, the PROTECT and the PREVAIL, that compared Watchman to anticoagulants in patients who were eligible to receive anticoagulants. Most of the practice today is based on patients who cannot receive the anticoagulants, therefore they would not have been included in the basic studies. And most of our knowledge is based on large registries that treated patients who could not receive anticoagulants but received antiplatelet aggregants. A recent meta-analysis of more than 12,000 patients showed that the results with these patients was more or less similar to the results of the randomized controlled trials. Based on this knowledge, we designed this scheme of treatment that is included in the paper that I presented to you of who should get LAA occlusion. Patients who are suitable for oral anticoagulants should not receive the occluder, but should receive DOACs because there's much more evidence behind it. Those who have contraindication to oral, absolute contraindication to oral anticoagulation should receive occluders as long as they can receive at least, we thought, 2 weeks of antiplatelet treatment. And there are other groups in between that we don't have the time to go into. There is a recent contribution of the PRAGUE 17 trial that was the first one to do a randomized control comparison between LA occluders and NOACs for the first time. And the LA occluder was non-inferior to NOACs, which is encouraging, although there were almost 5% procedure-related complications. Two more recent contributions to the understanding of LA occlusion. One of them is the issue of treating patients with single antiplatelet therapy following occluders. There are data in the different registries of LA occlusion that support that single antiplatelet therapy can be used in patients at high risk for bleeding. And there was a recent meta-analysis that also supported this as a relatively safe practice, although in one of the registries it was associated with high risk of device-associated thrombi. It was not associated with any clinical outcome. And there's even some, but too small evidence for the use of no antithrombotic therapy at all in patients at extremely high risk. We, as the writing group, did not think we had enough evidence to support it, but just to mention that some patients were not treated with any antithrombotic treatment after receiving LA occluder. We thought that at least 2 weeks of single antiplatelet agent is the minimum that is needed to recommend the LA occlusion. So this is about it regarding LA occluder in 5 minutes. And I would like to invite you to this meeting that we are holding virtually in a few months. Thank you very much.
Luca Santini from Italy, Roma.
Hello, everybody. It's really a pleasure to be here. I would like to thank Professor Ozerov and for inviting me and say hello to all the friends here. So we will talk about telemedicine and heart failure in 5 minutes, okay, which is really a very actual topic. Move, please. You know that the heart failure is really a true pandemic affecting more than 26 million people worldwide. Move, and the scenario we are living is facing us with global disease, chronic disease, increased burden, besides, on the other side, to a dramatic reduction in healthcare workforce. Move. So there is this mismatch which is really challenging us daily. And if you put on top of this the COVID pandemic, you can understand how much we are in trouble. Move. We need a help that can come only from a revolution, a digital revolution, which is called e-health. Please. And you know that now we have an availability of many different sensors that can record every single parameter. Majority of them are wearable and will be very soon invisible. Move. And everything that is digitalizable will be digitalized, and what is not digitalizable so far, I'm sure it will be very soon digitalizable as well. Move. And actually, as EP, we already had an experience with telemedicine because we started in the first 2000s with the remote monitoring of implantable device, and we soon understood that the majority of data were from clinical data, so that we could move to a remote patient management move. And actually, remote management is a gold standard. But if you can see guidelines put for AF in a class 1 recommendation, but for heart failure just in a class 2 recommendation. And this is because majority of trial, but in time, got negative or neutral results. Move. The reason may be different, but they include organization, technology, which is not the same for all the systems. But I think the most important is the kind of analyzed data. Move. Because if we only are focused on a single parameter, like for example, thoracic impedance, we will have bad results. We should move to a multi-parameter monitoring, which will include many data. Move, please. So we are dealing with another problem, because taxonomy of this disease is changing. Now cardiovascular pathology are not anymore static. They are dynamic, highly dimensional. We need to take into account when we evaluate an heart failure patient, for instance, imaging issue, biochemical, genetic, and so on. Move. So we need big data analyzing, but it's not only a matter of collecting data. We also need to know what to do with this data. Smoothly. It's not only, it's easy to get data, but it's much harder to use them. Okay, move. Move again. Okay, and we need a help that will arrive from artificial intelligence and machine learning, which will be already are and will be more and more disruptive in our clinical practice. So, for example, if you think about heart failure, when you evaluate a patient, you give him all these questions. If you picture to have all the answer in just one composite index, which will take into account heart sounds, impedance of the thorax, breath and rate, respiration, the activity of the patient, and so on, you will for sure be helped having just a simple number which will advise us if something is going wrong. This as a tool which has been evaluated by many trials. The first one was the MultiSense trial, and it's the HeartLogic, which is working very well. Move. And this is just driving to many publications. This is how it works, and all the industry is moving in this direction. You can see on the right also another tool like that is the SLN from Biotronic. So all the industry is moving in this direction. Move. And of course, the final answer, it will come from the randomized managed HF trial, which will randomize patient to a standard of care with remote patient management together with another group, with including the HeartLogic alerts in the management of patients. So it's really a big challenge, and we also know that we should take an early decision in this patient, because when they say I feel healthy, it doesn't mean that they really are healthy, because heart failure, move, please, is a pathology which is progressive, and when also a patient, you can move, is in a functional class 1, is already undergoing to structural disease. So we need to be very proactive, very early in our treatment. Okay, you can move. Move again, already say this. Thanks, Federico. So it's a big challenge, a huge opportunity. Move. We should also take the advantage, like Einstein said, that in times of crisis, we can have great opportunities, and this is a really crisis time with the COVID pandemic. Move. Many scientific associations push the implementation of remote monitoring in our clinical practice. Move. And we will even use it much more in the future with the ability of new kind of data, hemodynamic, biochemical. So that's really the challenge we will face with. Move. We will have to manage a lot of data in a very fast time. It's a new info ecosystem where we should get well very soon. Move. And so we never should give up with the clinical judgment in any way, because we should always remember that this is our polar star to put together in a linear, logical, sequential way our evaluation. So otherwise, move, the final one, we will make the end of Charlie Chaplin in modern times, where he is fed by the machine and he is not able to do anything else. Thank you for your attention. And thanks, Federico, for support moving slides.
Thank you. It's a privilege as Secretary of the World Society of Arrhythmias to be able to introduce the topic of the journal with which we will be associated, and Brad Knight, who is the editor-in-chief. Just a word or two about the history. The JCE, Journal of Cardiovascular Electrophysiology, started with Doug Zipes as editor-in-chief in around 1991 and became very successful, a leading journal in the field. Was taken over later by Eric Brostowski, who maintained it at a very high level. And Brad came on the scene quite recently, moving from PACE. PACE, of course, was the journal for ICPES as we used to be. We became WSA in 2007. We continued with PACE and with John Fisher, for whom we have great respect. But things changed with PACE, and Brad moved to the JCE, and we were honored by his invitation to follow, an opportunity which we have taken with both hands. So now we are linked to this journal. The final arrangements are not quite made, but they undoubtedly will be in January. And it is my honor to ask Brad to speak about this.
Thank you very much. I appreciate those comments, and I appreciate the opportunity to present to this group. I'll briefly talk about the journal, JCE. Professor Sutton's already provided some of the background. I'll talk a little bit about our experience during the COVID pandemic, much like Mark Estes did, and then just a few of the accomplishments in the past year from the journal. As of January 1st, the plan is for the print version to now have the logo of the World Society of Arrhythmia and the comment that it is the official journal of the World Society of Arrhythmias. So we're very excited about this partnership. As of this week, the online version now on the banner has the World Society of Arrhythmia at that position. And again, the comment that it's the official journal of the World Society of Arrhythmias. So we're quite excited about this partnership. And has already been mentioned, I need to thank the editors-in-chief over the past several years. Dr. Ken Ellenbogen with Rod Tung were the editors for the past year, but Dr. Eric Prostowski was the editor for this journal for the past 15 years up until 2019. Again, I want to thank all my colleagues who have joined the editorial board. We have an incredible group who is now serving as associate editors and section editors. And if I had more time, I can tell you about each of these, but they are authorities in their field, and I have a personal relationship or have worked directly with many of these real experts. In the past year, we've had an experience, much like many journals have had during the COVID pandemic, of a significant increase in submissions. Unlike many journals, that has persisted throughout the entire year. As of September 1st, compared to the prior year, JCE has experienced a 55% increase in submissions, a 23% increase in papers published, a 48% increase in downloads, and a 34% decrease in the time from submission to online publication. Other accomplishments including publishing the abstracts of formerly the Boston AF meeting, the International AF Symposium that's held every January. We will continue to publish their abstracts. And we published the review articles from 10 speakers from the CAST AF meeting last year, and we'll continue to do that annually. We've had several objectives. One is to publish the high impact papers related to both catheter ablation and cardiac implantable electrical devices to provide a balance in the journal, as well as to attract novel papers regarding all aspects of cardiac electrophysiology, including arrhythmia syndromes and genetics. My bias has really been to make the journal comprehensive and balanced with a diverse content that represents the practice of most contemporary interventional heart rhythm specialists. I looked at all the papers that were published in the calendar year of 2020, very impacted by COVID. Also, to make sure that we have a good balance of topics. We won't have time to go into all these, but we published 267 papers. You can see that a bulk of them, 80 publications, were devoted to catheter ablation for atrial fibrillation, which I think is appropriate given the changes that have occurred in that field and how that procedure has become to dominate much of what we do in the EP lab. However, we have a very good balance here between ablation topics, implantable device topics, including physiological pacing and leadless pacing, left atrial appendage closure, and then other topics that I think are of interest to interventional electrophysiologists. We published 12 papers related to the COVID pandemic. And it's nice to see that if you look at the most cited papers based on publications in the last 3 years, number 3 with over 120 citations already is the paper that was published by Claudio Tondo's group on cardiac and arrhythmia complications in patients with COVID-19. We have also published a significant number of review articles, 15 of which were meta-analyses, the remainder traditional review articles, including articles by speakers at the CAST-AF meeting that we're hosting here at Northwestern, the cardiac arrhythmia or catheter and surgical therapies for atrial fibrillation. We've also published important case reports, including those that are formatted for EP rounds, edited by Dr. George Klein, and device rounds edited by Dr. Chuck Love. We've established a Twitter page, and I would encourage all of you to, if you're on Twitter, follow the journal. It's at JCardioEP. Hawkins Gay, who's one of our incoming EP fellows, who's doing an AI fellowship this year, is our new social media. And finally, to download your the app, which is available to anyone, and you can read the abstracts from all the journals as they're published. It's a really good way to stay on top of the journal. I'll finally finish with this picture of me getting a vaccine yesterday, which is probably the most exciting thing I've experienced in the past 9 months. So thank you.
Thank you, Dr. Knight. Our next speaker is Dr. Eric Bristowski from USA.
Thank you all very much. I chose, since it's such a short talk, I decided it would take me longer to make up 6 slides than it would be to just give the talk. So I'm going to go from notes. Brad, first of all, having spent 15 years running the journal, I really want to congratulate you. And I can't even imagine what this year's been like being an editor-in-chief during the COVID crisis. So great job. And I actually took a picture too yesterday morning. It looks just like yours, except I'm a little heavier, but getting it in my arm because my fellows, I run the training program, it made me promise I would take a picture and send it to them so they could show everybody it's okay to get the vaccine, because we have a number of people in our area, including doctors, who are still hesitant, believe it or not, to get it. But anyway, thank you to everybody. It's great to see all the faces. I chose the title based on one of my favorite writings from the early 1600s from John Donne, and it's his famous piece on No Man is an Island, and it says the following: "Each man's death diminishes me, for I am involved in mankind. Therefore, send not to know for whom the bell tolls; it tolls for thee." So when you talk about risk stratification for sudden death, which is really the therapy of PVCs and VT, some things are very obvious. So, and it really doesn't take much discussion to talk about those. So what are the obvious things? If somebody has sustained VT, we treat it. I mean, I doubt if very many of us leave that alone. And how to treat it? More and more of us would certainly go to ablation. It doesn't have to be ablation, but I think I would think probably Brad would agree with me in the United States. This is really the major thing we do. I think the PVC issue becomes a little more difficult because if they're symptomatic, you can suppress them, and it often doesn't take much to suppress them. We all know that. I mean, some beta blockers, outflow tract might be calcium channel blockers, but more and more, many of us are, again, extending ablation to that, to that area. The other areas I think needs more research is just when to step in for the PVC cardiomyopathies. I don't know what other people do. I do routine echoes, but I'm not just worried about ejection fraction. If I see any minor dilatation in the ventricle itself, I will tend to step in, and we usually will treat those with ablation. But I'd like to spend just 1 or 2 minutes on what I think are the problems for the future. What do you do in the not so obvious situation? And I'd like to give you 2 things, and I'm glad Mark Estes is on. Maybe we'll get a discussion later. One is the hypertrophic cardiomyopathy group. I think non-sustained VT has been grossly overrated in this group. I think that many people have it if you monitor them long enough. The original studies talked about maybe a 1-day or a 2-day Holter. Now that you put days and days of monitoring, I mean, very often you'll get 4 or 5 beats of VT. And I don't think that personally, in my experience, has much discriminating features for risk for sudden death. And I think we need much more research in that area. We are woefully behind in researching apical hypertrophic cardiomyopathy. All the guidelines really direct themselves to classic HCM. And the apical variety is being recognized much more in Western civilization. In Asia, it's been known for years, but it's often missed on an echo unless you direct someone to it by noticing the ECG gives you clues. You might miss apical hypertrophs. And we really don't know what to do with them. So if you get someone with apical hypertrophic cardiomyopathy and non-sustained VT, do you worry about that patient? Do you leave them alone? I think we need more research. And for me, on a personal level, I'll end with this. I think my biggest concern these days, and I've been into this area for several years, is this whole mitral valve prolapse and now mitral annular, disjunction that's gotten thrown into this. I really don't know exactly how to treat those patients. And you often get patients who have prolapse, and you don't have to have, as was thought decades ago, marked mitral regurg and redundant valves. People can be at risk for sudden death even with mild to moderate redundancy, mitral regurgitation, and bileaflet involvement. And if you have, let's say, high-grade PVCs, 20,000 a day, even patients I've had are asymptomatic. We know those are risk factors for sudden death. Do you just ablate them and call it a day? Should they get a defibrillator? Should you do both? I actually don't know, and I think this is a fertile area for investigation. I'm trying to start a worldwide registry on it. I've been working with a company on that. It hasn't come off the ground yet, but this is not an uncommon problem. It's getting recognized more and more, and I hope all of us in our various countries and societies will get involved in this. It comes up frequently, and nobody knows how to handle this problem. So I'll stop at that point. I hope we'll have some time to discuss things in more detail later. And again, it's great seeing everybody. And Oscar, thank you for the opportunity to say a few words.
Thank you, Dr. Pristowski. Our next speaker is Dr. Eugene Crystal from Canada.
Hi guys, here we go. Do you hear me well?
Yes.
Thanks. So thank you for invitation. I'm really humbled to be between such distinguished speakers here. I was tasked with robotics in arrhythmia, and that's how I call this talk. I will closer to the second version of this world. Give me a second. Here we go. So it's not that rare to to see the robotic or automated trucks on a highway anymore. But in EP labs, the robotics is actually rare, and it's probably less than 5% of all EP labs. What is not so rare is that we see a series of expired EP robotic systems. As you know, Hansen is gone, Magnetics is gone. One of the more recent fall-offs, to my knowledge, was Vitronos, which was a robotic system for ultrasound-based imaging and ablation for atrial fibrillation. What we still left with is actually remote magnetic navigation, which is seems to be surviving 20 years of the clinical use. The company declared more than 100,000 procedures done. That was about 2 years ago, with about 120 active labs and 300 operators worldwide. Atrial fibrillation accounts for a majority of the procedures, and various peripherals were developed to help move more than one catheter. And the key point for that company and for that technology is really safety, because the complications are invariably down by 50 to 75%. The one of the interesting observation is atrioesophageal fistula, which is super rare, probably about 30 times less likely. And if fluoro used, it's much shorter too. And this is one of the more recent meta-analysis on the second version of the system use, and you can see significant reduction in complications. And the efficacy is pretty much the same in terms of outcomes of the procedures. The 1 year and longitudinal follow-ups are really not inferior to the non-force sensing catheters, but also to the force sensing catheters, which is probably one of the most important novel developments in RF catheter technology. The RMN also came up with a, I would call it a similarity in terms of contact and the force. It's the e-contact model, which is estimate of the permanence of the contact during ablation, and also amount of the energy deposited to the tissue. And that is easier with these systems because we roughly know what the contact force is, and it's pretty consistent. Obviously, the robotic systems are not as intuitive as we want it to be for all of them, but particularly for stereotaxis, you need about 25 or 50 procedures before you are proficient. You're still forced to use steerable sheaths. There is a significant problem of a cost of installation, although a company did develop a new version with new X-ray system coming with it from Omega, and that appears to be a little easier. And then there are operational costs which are at the moment incremental. The new system, which was just launched in 2 centers, one in North America and one in Finland, called Genesis, and just 2 days ago there was a webcast of the procedures done with that system. It's obviously slicker and faster system, but it's still using the old catheter. And here's a new catheter which is coming, which is having a faster movements, even better contact, and is conditioned for surround flow. That catheter will be in Europe probably about 2022. So the mapping integration is still a problem. It's complete with CARTO and Acutus, but it's incomplete with Abbott, Rhythmia, Insight, despite the fact that a robotic company did make the important move and opened its own software to any mapping company. Seems as the mapping companies are not quickly moving to that area. And one of the most exciting things is actually telerobotics, because this system actually allows live procedures to be done on a greater distances. So with the solid clinical evidence, that seems to be the only robotic technology is surviving at the moment. I do think that after a novel catheter will be in, there will be even faster procedures with stereotaxis done. But masters of us, those who do stereotaxis procedures en masse, already do 4 or 5 procedures a day on the system. The limitations are obviously it's all RF-based technology, 1 catheter at a time, and adoption is very challenging. So that's my up to date. Thank you.
Thank you very much, Dr. Crystal. The next speaker is Dr. Abe from Japan. Dr. Abe, welcome.
Can you see the slide?
Yes.
We can see it, but you need to put it in presentation mode, Dr. Abe.
Okay. That's okay?
Perfect. Thank you.
Sure, thank you. Thank you very much. My name is Abe from Japan, and my title is Syncope in Commercial Drivers in Japan. This topic is very interesting and important for syncope specialists, but also for occupational healthcare physicians in several companies. So ESC syncope guidelines 2009 recommendations separately in private drivers and commercial drivers, while in ACC/AHA Heart Rhythm Society guideline 2017 only recommended the importance to inform the driving laws and discuss with the patient. So loss of consciousness during the driving due to health-related cause affects several social situations. For example, sudden cardiac death or sudden death, and traffic accident during driving with or without carrying passengers injury, or restriction of working or retirement, or depression. So in Japan, annual incidence of death or injury in general traffic accidents decreased gradually. However, incidence in commercial drivers are gradually increasing. We have 65 million workers in Japan, almost about half of the total population. Of those, 1,270,000 people, this was 1.9% of Japanese workers, is working as commercial drivers, which includes in truck driver 68%, taxi driver 22%, and bus driver 10%. As a legal obligation, when the traffic accident occurs, companies have to report as soon as possible to ministry in Japan. So in 2015 to 2017, total 815 cases are reported. You can see that the spring and summer season seems relatively low incidence of commercial drivers' health-related accident. Bus driver is the most popular in 55%, truck is 25%, and taxi is 90% respectively. The cause of health-related accident during the driving was most common in cardiovascular disease in 25%. Cerebrovascular neurological disease is the second in 17% in commercial drivers. Incidence of complete loss of consciousness during driving was observed in 29%. Near loss of consciousness was 8%. Total 37% commercial drivers has shown disturbance of their conscious status during their driving. The slide shows the correlation between drivers' conscious status and vehicle damage. You can see that if the driver has complete or near loss of consciousness, vehicle accident is very high. But if the conscious status has no changes, vehicle damage is very rare. Sudden cardiac death was also observed in 111 commercial drivers in 30.6% in 815 reported cases. This is also a very high incidence. Sudden cardiac death was observed very popular in truck drivers in 38%, but very rare in bus drivers in 1.3%. So in Japan, complete or near loss of consciousness during driving was observed a very high incidence in 37%. And sudden cardiac death was also very high in 30.6% in commercial drivers. Complete or partial loss of consciousness was highly associated with vehicle accident. Thank you very much.
Now I'm going to introduce the next speaker, Dr. Supply Harenut. She is from Japan. Doctor?
Good day. It's my pleasure to join this webinar on update in electrophysiology and pacing in 2020, hosted by the World Society of Arrhythmias. My name is Chu Pak Lau from Hong Kong. I'm a past president of the World Society of Arrhythmia and immediate past president of the Asia Pacific Heart Rhythm Society. I was asked to update a hot topic in on-device therapy, and my pick is leadless pacing as the major breakthrough for patients who need bradycardia pacemakers. Traditional pacemakers, which we have used for 50 years or so, are associated with complications that are related to the lead and the physical presence of the pacemaker in the pocket. To be able to deliver pacing therapy without an intracardiac lead attached to an external pacemaker will reduce such complications. Importantly also, by removing on the body surface any reminder that the patient is device dependent goes a long way to bring patient satisfaction. Compared to traditional pacemakers, leadless pacemakers have implantation success rate, 30 days complication rate, and dislodgement rate comparable, if not superior. In addition, the 6 month and beyond efficacy rate in terms of electrical parameters are highly comparable. Who needs leadless pacing? The indications are now evolving. Because of the remaining lingering issue on replacement at the end of service, they are intended at the present time for the elderly, for those with limited survival, sedentary lifestyles, and comorbidities. The rhythm that serve them at the moment are permanent atrial fibrillation and those who do not require frequent pacing. However, there are emerging publications of the use of leadless pacing in the ventricular-only mode for vasovagal syncope in whom DDD is conventional, and there has been individualized choices of using leadless pacing for those who are young and who have atrioventricular synchrony are needed or who require atrial pacing. Procedural issues are now being overcome. For instance, overcoming venous access, tricuspid annuloplasty, and others. Importantly, the appropriate right ventricular site for pacing to avoid the risk of perforation, such as the mid-septal area, are defined. And the issue of the leadless pacemaker causing tricuspid regurgitation is also an issue that needs to be addressed, and the distance between the back of the leadless pacemaker and the tricuspid valve may be an indication of the risk of having tricuspid regurgitation. And finally, it's very important to overcome the issue of replacement and extraction of the device. So the current development and the way forward include the development of atrioventricular synchronization. This is to a certain extent achieved with the implanted accelerometer to detect atriomechanical sounds. The use of this device in conjunction with an intracardiac electrode from a subcutaneous ICD allow both right ventricular pacing and also anti-tachycardia pacing. And with the use of an external delivered energy to small intracardiac electrodes, allow endocardial leadless pacemakers for cardiac resynchronization therapy. I believe the leadless pacemaker has a bright future in 2021 and beyond. It will certainly replace more and more of the current traditional pacemakers and changing the field of device therapy to increasingly a leadless approach. I hope the 2021 will also bring a bright future for all of us here. May I also take this opportunity to wish all of you a Merry Christmas and a very good 2021. Thank you.
Greetings to everyone. It is a great pleasure and a privilege to be participating in this meeting of World Society of Arrhythmias. Thank you very much, Professor Oscar Zeroff, and congratulations for your constant work in favor of the electrophysiology and artificial cardiac stimulation. We are going to address the theme Cardioneuroablation Advances, Treating Bradyarrhythmias by Ablation. I am Dr. Pachon, Professor of Post-Graduation Program at the University of São Paulo and the Director of the Arrhythmia Service of São Paulo Heart Hospital. There is nothing to be disclosed. In the 90s, by studying normal hearts by using spectral analysis, we found that the atrial wall is composed by one very well-connected myocardium, the compact myocardium, and by another one, composed of loose cells, the fibrillar myocardium, which clusters gives origin to the atrial fibrillation nests. We observed that the atrial fibrillation nests were related to the innervation entrance. We can see that the atrial fibrillation nest ablation caused a dramatic reduction of the vagal innervation, pushing down the SDNN from 130 to 27 milliseconds. Based on the possibility of getting a vagal denervation by endocardial radiofrequency ablation, we proposed the cardioneuroablation, which aims to eliminate or to reduce the vagal tone through endocardial ablation. Only the parasympathetic postganglionic neuron is located in the heart, so it is the most affected by endocardial radiofrequency energy. The most important areas to be ablated are that ones overlapping the ganglionated plexi. It is very important to apply more radiofrequency energy in the areas overlapping the ganglionated plexi because the RF overpasses the atrial wall, making possible the ganglionated plexi ablation. The main ablation points are the left interatrial septum, the medial superior vena cava, the coronary sinus roof and the coronary sinus insertion, and the medial inferior vena cava. In some cases, it is necessary also to eliminate more atrial fibrillation nests on the insertion of the pulmonary vein and on the Waterstone groove. During the cardioneuroablation, the denervation must be very well controlled and confirmed. For this purpose, in 2015, we published the extracardiac vagal stimulation method that may be easily obtained by a catheter inside of the internal jugular vein without contact with the vagus nerve by using a customized stimulator. The effect is an immediate and transitory asystole and or AV block that must be completely abolished after the cardioneuroablation. We can see a short movie showing the progression of the catheter up to the internal jugular vein close to the jugular foramen. This is the best place to get the extracardiac vagal stimulation. I would like to present the case of a 16-year-old patient having syncope and seizure for the last 11 years, being treated with antiepileptic drugs. As the neurological treatment had been ineffective for several years, the neurologist referred to us for cardiological investigation. The first step was to perform a head-up tilt test, showing one asystole of 28 seconds, reproducing the syncope and a grand mal seizure by a huge reflex vagal response. The vagal stimulation in the current case showed a very long asystole due to sinus arrest that ended with a very slow sinus rhythm recovery. It is important to see that the extracardiovagary stimulation reproduced the same effect that was observed in the TUTI test. After the cardio-neuroablation, the extracardiovagary stimulation was repeated in the same point and in the same way. And it was observed that there was no more bradycardia, no more asystole, no AV block, meaning that there was a complete vagal denervation obtained by the cardio-neuroablation. And here we can see the outcome of this patient. He is evolving without any symptom and without medication 51 months after the cardio-neuroablation. The TUTI test repeated 80 months after the treatment showed a completely normal response without any reflex vagal effect. So in conclusion, we can say something about the potential indications to cardio-neuroablation. It may be indicated to treat reflex bradyarrhythmia like cardio-inhibitory vasovagal syncope, mixed vasovagal syncope, situational syncope, neurocardiogenic ictal bradycardia, and glossopharyngeal reflex bradycardia. And it also may be indicated to non-reflex bradyarrhythmias like sinus node dysfunction, functional AV block, bradytach syndrome, vagal atrial fibrillation and paroxysmal atrial fibrillation, carotid sinus syndrome, familiar bradyarrhythmia, and overtraining bradycardia. Thank you very much.
So thank you, Jose Carlos. Now we wish to have our last presentation from Adrian Baranchuk, Canada, who will speak about cybersecurity and cardiac devices, myth and reality. Thank you.
Hello, friends from the World Society of Arrhythmias. Thank you for the opportunity to speak 5 minutes on cybersecurity and cardiac devices, myth and reality. I have no conflict of interest for this presentation. And through this presentation, I would like you to think about the balance between things that are possible and things that are probable. So things could be possible, but very unlikely. And the story behind the cybersecurity and cardiac devices perfectly fits into this picture. As you know, around 2016-17, a group of people composed by EPs, safety, security, stakeholders, and lawyers put a case called the Muddy Waters case, stating that a 15-year-old kid with a simple device buy in an internet store could produce a massive attack to patients with cardiac devices, producing basically two things: what they called the crash attack, which was a total malfunction, and a sudden and non-reversible battery drain. And the description of these two attacks, the crash attack and the battery drain attack, were posed to the media before contacting specifically Abbott, who was the company, where those devices could be attacked. This had a huge repercussion, a huge economic impact in stakeholders of these companies, until it was demonstrated that these attacks were very unlikely to occur. And by December 19th, there was no clinical attack to a patient. Of course, that took the FDA to pose a warning early in 2017, and for Abbott to have to take immediate response, basically creating firmware upgrades, which are software patches that could improve safety of pre-existent devices. And this is the huge list of devices that were already implanted in different individuals across the world who were able to be victims of this possible but unlikely attack. This takes several groups, including ours, to advance science on this regard. And of course, when you explain to patients that the possibility or the possibility exists, but the probability is very unlikely, only a fragment of those patients, a fraction of those patients accepted to have the firmware upgrade, as Abbott quoted up to 3% of complications. This is one of our patients that during the firmware upgrade developed a transient shift to unipolar pacing, leading to a 3-second pause, which in this case was asymptomatic, as you see in the bottom, due to the presence of underlying rhythm. However, these kind of things could happen. This took the American College of Cardiology to put a position regarding what were the areas of vulnerability and what would take different groups to be able to successfully attack, and how to produce the defense via firmware upgrade. And I had the pleasure of leading that paper in JACC a couple of years ago. And at that time, we were calling for better groups to fight against this unprecedented challenge, and to put the things into perspective to not increase excessively the fear of the patients regarding these possible attacks. And then it came this interesting work from Ransford and collaborators that showed that those attacks were not reproducible, that the best that they were able to find was a transient interruption in communication between the remote monitoring aspects of the device and the devices itself. I recommend you to read this if you still have some doubts regarding these issues. And then other societies put similar position papers. This one, for example, is the Heart Rhythm Society, who also calls for more integrated approach to this. Of course, in the news, that generated some panic in the patients, mostly for patients with defibrillators. And there were this type of articles that were quoting the risks that at that time the Vice President Dick Cheney could have by having an ICD and being able to attack by the Russians or whatever. So we advanced a series of articles with these young collaborators in this regard, trying to bring and shed some light on the lack of possible attacks. But here in red, you see a new source of fear for these patients that have defibrillators, that have to go through a life of fear, fear to die before the implant, or fear to receive a shock, or fear of a recall on their devices. Now we have to deal also on providing contention to this and reassurance to these patients due to the fear of a cybersecurity attack. And this is why we recently published the firmware upgrade for the defibrillators, where Abbott combined the BPA, the battery premature depletion alert, along with the cybersecurity firmware. And this resulted in this publication where we had no issues by uploading this firmware upgrade. And this ended up in Nature, as the topic continued to be in the high stakes. And I am super glad to finalize my presentation saying that up to December 19, there were no attacks to patients. So you can use all this data to bring some comfort to your patients. We need to create better teams integrating different stakeholders of this topic. And I thank you very much for your attention.
Much, Adrian. Thank you to all of you, my dear friends. I feel very proud for the World Society and for SADC of having had the opportunity to all these outstanding speakers that we had. And I feel that we are going to have future of these presentations, probably with more time, but we needed to be in time and to say goodbye to this year. Ali, you are going to share with me this moderation of questions that will appear or comments from anyone just before finishing, because we really feel that the scientific topics were so well presented in 5 minutes, and all you respected everything, that I feel we are really very proud in the name of our two societies, how you had here and you to have the possibility to make a synthesis, to make a home message of this very important topic. I know all of them are important enough to be very well explained, but sometimes we need to do these things, and especially during this 2020 that hurt us a lot in our really healthy aspect that we needed to be together. Please, we have some questions.
Oscar,
Chat. Yes, Ali.
there is one question by Adrian. He asked Dr. Abe, if a person receives an inappropriate shock, do you hold the license of the driver? Dr. Abe?
Open your mic, Aruito. Yes.
If the patient has did not loss of consciousness, the driving is okay, no problem in Japan.
Yes,
And
there is a follow-up of this question, which is, if patient presents an appropriate shock from an ICD,
yes.
for how long do you hold the license?
No, if the inappropriate shock is no restrictions in Japan. But the adequate, appropriate shock is 3 months restriction. Is that okay?
Yeah. You should continue with the question that was made to Dr. Pachon relating, he answered by the chat to Adrian about the ictal bradycardia of a patient of 17 years. And also he's asking if atrial fibrillation is so frequently seen plus the pause of some patients. Can you make a comment on that, dear Jose Carlos? Open your mic, please.
You are still
muted. Okay. Thank you very much, Dr. Adrian, Dr. Ozerov, and congratulations for this meeting. Dr. Adrian asked me about a patient presenting ictal syncope, and I think this is probably a good indication for cardioneuroablation. Probably if you can do an atropine test, if the atropine test is normal, I am sure that this patient will be benefited by the cardioneuroablation. And also, it is very interesting because we are learning a lot with extracardiac vagal stimulation. During the atrial fibrillation ablation, there is a very good improvement of the results by adding the cardioneuroablation to the pulmonary veins isolation. So I think this field will help a lot the atrial fibrillation ablation. Thank you very much.
Can I have one question, Oscar?
Please.
To Dr. Pachon. Dr. Pachon, what is your preference? Left side, right side, or both sides of neuromodulation?
Thank you very much, Dr. Otto. This is a very good question. It was my great question at the beginning in the 90s, at the beginning of the cardioneuroablation. So in that time, it was very difficult to answer this question. And for this condition, we developed the extracardiac vagal stimulation. And by using the extracardiac vagal stimulation, the end point of the procedure is to eliminate the vagal effect. And I have been observing that to eliminate the vagal effect is necessary to ablate the left atrium and the right atrium. We have been observing several papers, several articles that have shown that the innervation is higher in the left atrium than in the right atrium, and is higher in the endocardium than in the epicardium. So in our procedure, it is very important to ablate the left atrium, mainly the left interatrial septum. But the procedure is controlled by the extracardiac vagal stimulation. So if we get to eliminate the vagal effect, I think the method is not important. Important is to eliminate the vagal effect. Thank you very much, Dr. Otto. Thank you.
Thank you.
Dear Eric, I want to make you a question because it's important after your reflections on what's happening when the toll is heard, you know. Are we going to use more or less defibrillators in the future? As you understand, we are doing more ablations and we are taking the number of VPCs as a way of protecting and ablating patients. I would love a reflection for a real expert like you.
Yeah, then I want to ask Dr. Pashan something.
No problem.
As a follow-up, if you don't mind, Oscar. I think Les.
Do it first. Do your question to Pashan.
Real quickly for Dr. Pashan. You know, one of the observations we made decades ago is that vagus affecting the ventricle, which showed very nicely in your case, because if you have asystole for that long, that's way too long for overdrive suppression of ventricular subsidiary pacemakers. So obviously there is a vagal effect on the ventricle. So just a question for you. Have you seen any downside effects from your patients? Any gastrointestinal effects, heart rate variability? Could you just briefly talk about that? I understand it's complex and depends which vagal site you hit, but have you noticed anything at all yet?
Thank you very much, Dr. Piotrowski. It is a pleasure to answer you. I have just published in Circulation a paper, an article showing the observation by 2 years of a cohort of 83 patients. And we have been observing that the cardioneuroablation makes a very important reduction and a persistent reduction of the parasympathetic tone and also to the sympathetic tone. It is very important because it makes a great difference of the patients after myocardial infarction. After myocardial infarction, you know that there is a very important reduction of the parasympathetic tone and increase of the sympathetic tone. However, otherwise, the cardioneuroablation causes a reduction of parasympathetic tone and reduction of sympathetic tone. I think it is very, very good for patients presenting ventricular arrhythmias, heart failure, atrial fibrillation, and also bradyarrhythmias caused by functional issues. About the question of the heart rate variability, we have been observing a good profile for cardioneuroablation.
Thank you. Well, I think time will tell if indeed it's all things for all people, but congratulations on your research. Back to you, Oscar. I think there'll be a reduction in defibrillator use, and I'll tell you where. I think that in the areas of non-ischemic cardiomyopathy, I've been very impressed with, I routinely and have been doing this for years, getting delayed enhancement from a CMR, from MRIs of the heart. And I think that many investigators worldwide have confirmed the early reports that your risk of sudden death, while not zero, is exceedingly low if you have no delayed enhancement. That's definitely true for the dilated cardiomyopathy groups. And it's, I'm still confused on the HCM group because it seems like it's not a black and white there or not there. It seems to be a percent of fibrosis, but I don't know that that's going to hold up over the years. I think it's more complicated than that. So if you take a look at the group of non-ischemics, I now use that as a risk marker. If they have no fibrosis, part of my discussion with the patient is you're still at risk, but very low. And some of those patients decide not to pursue the ICD. If I have a patient that I'm considering biventricular and they have no fibrosis, like a left bundle, no fibrosis, even if it's a low EF, frankly, I have a discussion with CRTP versus a CRTD. So for me, yes, I think there'll be less use of ICDs. Now, the other issue is, what about the boutique diseases, like the mitral valve prolapses, where it's hard to get RCTs and where we need more registry data. My hope, but I don't know this is true, is that if we ablate, let's say complex arrhythmias, and we do a good job with it, that will reduce the sudden death risk. But I don't know that's true. But certainly in the non-ischemics, I think we'll see a reduction in ICDs, and I think we'll see a reduction in CRTD if people take a look at other risk factors like fibrosis. But there are other people on here who are in this area too. I'll just throw that out. So yes, I would say there'll be a reduction.
Only to complementary that good presentation, Eric. Are you using magnetic resonance to check fibrosis in all ICDs indications?
I am. I've been doing this for a number of years now. We didn't publish on it initially because it just wasn't my main area of interest, but I was collecting it and I found some interesting things. I've been looking at it in great detail with tachymyopathies. I think, for example, too many people have assumed pacing-induced myopathy is pacing-induced. And I think people go too quickly to a CRT when actually, and even a P, when there could be fibrosis and a risk of sudden death. So I have found it to be an excellent tool, better than EF for me, frankly. There are papers published of good ejection fractions. I mean, like 45%, and higher risk of sudden death with fibrosis than a 30% EF with no fibrosis. So it makes sense, right? If electrophysiologists know scar is important for arrhythmias. So yes, I get it routine. I won't upgrade to a CRT until I've done the MRI first in a patient with pacing, because if I find that they have no fibrosis, I'll go with a P and not a D. So I do use it very frequently, Oscar, in my evaluation.
Oscar, may I comment?
Please, critics for just critics for Eric's presentation. I need.
Yeah. So this is a key question, and there is a trial which is ongoing now, prospectively looking at defibrillator implant in patients with well-preserved left ventricular function, that is 35 to 50% based on CMR. And as Eric's indicated, it is true that the fibrosis is a very potent risk stratifier for the non-ischemics and for the ischemics. And without fibrosis in the patients less than 35%, it's highly unlikely that they're going to get benefit. The dilemma we have is that all of the trials that serve as the basis for the guidelines are based on ejection fraction and in the non-ischemics, the functional status. So we don't have the data yet that even though the CMR is a potent risk stratifier for the non-ischemics and for the ischemics, that using it in an ICD-based intervention based on that risk stratification improves survival. There's a huge gap in the evidence right now. And right now, there's no trials looking at those less than 35% with CMR. Eric's alluded to the hypertrophs, but that 15% cutoff for CMR LGE is pretty robust, and it's now used as a risk stratification. So we have a huge gap in evidence between the old trials, now up to 2012, and current indications that I'm not sure industry is going to be interested in filling by restricting the use of primary prevention ICDs in that patient population. Eric, I'd be very interested in your thoughts.
Yeah, Mark, it's always, oh, by the way, I should have congratulated, I feel terrible. I congratulated my buddy Brad and didn't give you credit. I think that you've done a yeoman's job in your new area with the circulation, with the AHA journals. Can't imagine how much time you put into it. And thank you from all of us. It's a wonderful job you've done. I thought you could just retire to your horse farm there outside of Pittsburgh, but you proved me wrong again. So listen, I don't want people to misunderstand. What I'm talking about is my approach. I mean, absolutely, Mark is right. There are no hard data. And you would ask me, like, what am I doing? What I do is have the discussion with the patient. So Mark, I do not ever tell a patient you shouldn't get the ICD. I just say, you're in the at-risk group, but we now know you're at the lowest end of that at-risk group. If you want a defibrillator, I'm still willing to give it to you, but I want them to make an informed decision. So that's where I agree. I'm not as sanguine as you are on the hypertroph group. I understand, but I also know how difficult it is to measure the degree of fibrosis in that group. See, that's the problem. And most of the articles that have been published have been done by people, painstakingly measuring it. But for all the rest of us out in the real world, as we say, that aren't doing that research, we need a program that very accurately measures it. Before I use a number of 15%, I want to be sure it is 15%. So for me now, that's where I'm a little confused, because what if you have an apical hypertrophy? Maybe 4% in an apical puts you at risk. So we don't know yet, but I totally agree. It's going to have to be NIH or AHA sponsored. There's no industry I could think of that would want to hurt their product line. So would I do a study that's going to reduce the use of my product? No. Who would do that, right? These are corporations. So I wholly agree. Maybe it would be something you could do, set it up, I'll join you. But I think right now the data are fairly robust that your risk of sudden death in non-ischemics with no fibrosis is low. It's not zero, but it's really low. And I think I think we're putting in too many defibrillators in that group personally.
I agree fully. It's just the evidence base to change the guidelines doesn't yet exist.
I agree. Totally agree.
Dr. Adrian, I think has a comment. Can you just unmute yourself, please? Adrian, unmute yourself.
Here
please.
you go. Yeah, no, I was unable to unmute by the host. Thank you.
Okay.
So I would like to echo and re-ask Eric about this beautiful teaching condensed in a 2-minute answer. It's quite impressive, and thank you so much, Eric, for everything you have done and you continue to do. So a couple of questions in line. The first one is, until we have better qualitative and quantitative MRI, because I do an MRI and then I get the result, there is fibrosis, but I don't know exactly where or how much in relation to the total cardiac tissue. Do you have integrated the Danish data indicating that patients, for example, stratified by age in the non-ischemic group may present different type of risks to take decisions on a per patient basis? What would be your wise advice today, where we're still waiting for the perfect MRI, cheaper, quicker, easier to do, in order to decide whether we go against our traditional guidelines that, as we all know, were based on a quite modest benefit in primary non-ischemic?
Well, Adrian, thank you for your nice comments. And I have the same problem you do. That's why I said to Mark with the hypertroph group, the groups who are looking at that are doing painstaking measurements. We don't have that. I agree with you. We get back the same sort of thing. I think it's 5%. I think it's 8%. And so I don't know what to do either. But right now, I am using the presence of fibrosis to guide my therapy a bit in hypertrophs. But I'm not sure of the percent. I'm really not. If they have minimal, for me, it's a kind of a it's kind of like maybe that one extra feature that will push me one way or the other. But your question as far as the other patients, like with the Danish study, I don't know what to do with the Danish study. I after the Danish study came out, I promptly got put on as the con on about 6 stages internationally, because everyone knows I was pro ICD, and I was the guy doing the debate at CP's meeting, APHRS meeting. I think the Danish study didn't help me that much, if I have to be really honest about it, because it was a sort of a mishmash. I mean, they had a series of patients, Adrian, that I never see. I mean, 50% of my patients don't meet CRT in the non-ischemic group. I get the fact if you're younger, you'll be more worried, but we do that for almost everything. We always worry about the younger patients, except COVID, right? We're more worried about the older patients, but
good point.
I actually don't use Danish very much. I totally use the MRI data though. I really do. So I'll say a patient that meets Danish criteria, and even if they're 60 years old, if they had 0 fibrosis, honestly, I'd be comfortable with a CRTP. I mean, I really would. But the most important thing, Adrian, is the United States. Well, I'm going to call Biden and ask him to call you and put you on our cybersecurity after what we learned this week, because clearly our current people aren't doing anything. You seem to have a good handle on it. So,
thanks so much, Eric. As soon as I don't have to talk to the other guy, with Biden, I may be okay.
Don't be so nice, guys. Okay.
But Bradley, may I ask Brad? Come on, you're being quiet. I mean, what are you doing now in this area? I know you have interest in this area.
I'll be brief. I think the focus that we often don't talk about is the therapy. We're talking about a defibrillator or no defibrillator, and we all know there's downsides and trade-offs to implantable devices. I just saw a lady at 5 o'clock yesterday who's 40 years old, has a non-ischemic cardiomyopathy, class 1, who's unfortunately about 300 pounds, and someone tried to put a sub-Q ICD in that's now infected, doesn't work. I think we need to focus on better ways to come up with ways to treat sudden death. So we talk a lot about risk stratification, but we should be focusing more on better extravascular devices and novel ways to defibrillate people. I think that's an important topic.
Oscar, I want to make 3 quick points. One is that all of the meta-analyses done on the non-ischemics have shown consistently that there's a benefit with the defibrillator. So the Danish trial, as Eric's indicated, is an outlier. 2 is that the Danish trial published their results based on MRI in a publication in the American Heart Journal recently. And they showed that the MRI predicted total mortality, but there was no benefit to the defibrillator based on the MRI findings. And the third, Eric, is I haven't retired. I am still very active clinically.
That was a joke.
Yeah, I know, full-time appointment. In fact, I'm working harder than ever, as I'm sure Brad is, and as I'm sure you did as the editor. That's a full-time job in addition to trying to do the clinical stuff. So I'm still very active clinically.
Well, I hope you know that was just a joke.
Yeah, understood.
Mark, my problem is that when you dichotomize prolongation of life as a yes/no, but you don't take into account for how long an intervention that is not a static, because if I put a primary ACD in a 55 or a 60, I may change that battery at least a couple of times if the patient survives, is the time of prolongation. And I was laughing when Brad was talking, because I had 2 patients yesterday, primary prophylaxis implanted 2 years ago, comes for regular checkup, and a month prior had ventricular fibrillation while sleeping, received a shock, he didn't feel it. And this guy is still alive and telling the tale just because we decided to put the ICD. And then I saw a 69-year-old woman, super active, ejection fraction 28%, on Entresto, super optimized heart failure. And she's in front of me saying, I have still a long run to go. I have grandkids, I have dogs. I am full of life, and I am booking her. She has a huge left bundle branch block, New York Heart Association class 2. And I went to a CRT-D. And after listening to Eric, I was still thinking, well, eventually, I can turn off therapies. But if I go CRT-P and she dies with that in place, I will kill myself. So I'm still need your wise guidance and your personal guidance on case by case until we have large series review in all these indications.
So Adrian, just so I don't get misunderstood, I mean, I put in a lot of defibrillators. So I think Oscar was talking more from the view of where my thinking is now versus maybe 7 or 8 years ago. So I mean, a week doesn't go by. I'm not recommending one. I'm just going through a transition in my own thinking. And a patient like yours, a young person that I'm not sure, I would probably do a CRTD. I mean, that wouldn't bother me. But if they maintained a good ejection fraction for the next 4 or 5 years and the device changeout came, I'd almost surely switch them to a P, as long as they didn't have fibrosis. So I've done that too. I have the same emotional problems that we all do when you're facing a younger patient and you don't want them to die suddenly. But I was looking at a broad picture, and I think as a field, I'll be honest though, the other thing, Oscar, is there's a very alarming paper out there, alarming from the view of worrisome, that if you have even a reasonable ejection fraction, like I said, 40, 45, 50, and fibrosis, you're at a higher risk of sudden death than the low EF without it. And yet none of us, I mean, you can't put a defibrillator in that patient. And I had a patient like that who I've been following for years, about a year ago, who had a cardiac arrest. Fortunately, he made it, but not without a little neurologic problems. And he was 55%. And I've been following him for years for AFib, and I've been worried about him. And then he suddenly had a cardiac arrest, and he's always had the fibrosis, but there was nothing I could do about it. I mean, I can't put a defibrillator in someone with a 55% EF with fibrosis. So I think we're also missing some on the other end of that spectrum that we should be worried about.
Ali, just a comment and then we finish, please. Just a comment from you, dear Ali.
Just a few words from WSA. Many thanks to our great friends for their contributions to this very interesting and important gathering, I would say. And thank you, Oscar, for the idea, for the concept and the organization of this webinar. And I wish you all a very healthy, first of all, very healthy and Happy New Year.
Thank you, Ali. So
thank you, Ali.
From my point of view, I am very proud having you, my dear friends, all of you, being all this time present during this meeting, that it was like a view and like a starting again our World Society to be alive. And I hope that next year is going to be moving. And I thank a lot to SADC, the local society, to helping me to be alive during this year. And I really think that my best wish is for a happy holiday to all of you, my dear friends, and hope next year is going to be a good one for all. Thanks a lot. Sorry for not having given you all the time you need, but you are so important. Just to see your faces makes all important and transcendental for our life. The best for you, and thanks a lot. Very happy New Year for all. Bye-bye.